melanoma is a tumor entity that has a very high frequency for mutations, especially UV-induced mutations. And some mutations are shared with other cancer types, others are not. Actually, we should not talk about melanoma, but we should talk about the melanomas, because there are many subtypes, and today we start to define them based on their mutation pattern. For example, there is BRAF-mutated melanoma, there's NRAS-mutated melanoma, there's c-KIT-mutated melanoma, and now we still continue to find new subtypes. So there are subtypes that are characterized by NF1 changes, and very recently the US groups have described translocations that lead to the activation of oncogenes such as BRAF or others. And this is very interesting because they can be targeted by medications. Today, we do at least 3 different tests for mutations. We already do some tests for protein expression. We also investigate tumor suppressors such as p53. And this information together gives us an avenue that we can follow for the treatment of the individual. In my opinion, melanoma is a paradigm for personalized medicine or precision medicine. It's really ahead of many other malignancies. So for me, in a patient with stage 4 disease, it is essential to have a list of mutations checked, and maybe in the very near future we will also check for translocation. But there is also another level that is relevant, the protein level. For example, I want to know, does my patient express cancer testis antigens that can be used for vaccination, or how is his immune status? There are molecules such as PD-1 ligand that predict the outcome of an immunotherapy. Biomarkers are the basis for precision medicine. Without biomarkers, precision medicine will not become reality. So we have to invest a lot of energy in finding new biomarkers. But finding them is just one side. We have to know what is the exact value of this biomarker and when we can use this marker. The duration to validate a biomarker depends what is used for, but the most relevant biomarkers are biomarkers that have an impact on survival and can predict survival and identify high-risk groups, and this can take a very long time. The future for melanoma therapy, in my opinion, really looks bright. We have many new options. Actually, in my daily practice, I avoid chemotherapy in many patients. We use targeted therapy and we use immunotherapy. We have successful examples for both treatment options now, and there are already the next molecules in the pipeline. We have combined BRAF inhibitors and MEK inhibitors and could show that these 2 molecules increase the progression-free survival without having more toxicity. And similar is the situation with ipilimumab and anti-PD-1 antibodies. We have proven evidence that ipilimumab has a long-term benefit for our patients, and now we can add on additional strategies. And if we manage to bring targeted therapy and immunotherapy together, I think this will really result in a much better prognosis for our patients. We are carefully monitoring the survival times of patients also treated outside of clinical trials. And within our institution, we can see a significant improvement over the last 3 years.